Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today in the Conversation with Cancer Experts series, we have Dr. Ola Abdallah, who's associate professor and leads the plasma cell disorder program, multiple myeloma, amyloidosis, and other disease states in the division of heme malignancies and cellular therapeutics at the University of Kansas Medical Center. And we're going to talk about how he plans to use CAR T cells post first relapse in myeloma given recent FDA expansion of the indication. So welcome, Abdallah.
Thank you very much, Dr. Ravi. Thank you for introducing me here and inviting me to this event.
So I guess, we have so far had a growing armamentarium of drugs in multiple myeloma. And you know as well as I do that we've had so many of these three drug regimens that have come about. They all are based on, proteasome inhibitors, immunomodulatory drugs, monoclonal antibodies, and for some also the selinexor-based three-drug combination. But now we're moving into a new era. And that's what we're going to talk about today and the approval of CAR T cells in earlier lines of therapy. So let's just start out with the CARTITUDE-4 study. So can you tell us about what this trial design was?
Absolutely. I mean, I think it's really also a great time, for us as myeloma physician, because we're now seeing one of the treatments that have been actually very impressive results in the later lines of therapy, although it was a phase 2 trial, single arm. But to see it moving up front, forward in early relapse, that was something very an excitement news for us. The CARTITUDE-4 study was a study that actually designed to actually compare cilta-cel, which is one of the BCMA targeted therapies, against a standard of care. The standard of care arm, as you mentioned at the beginning, there is many treatments options for the patients in early relapse, and mostly we use in our myeloma in our communities triplet therapy. And this arm included pomalidomide, Velcade, dexamethasone, or most commonly at that time was darapom-dex. These patients were well known that they either receive 1 to maybe 3 lines of therapies, but they have to be Revlimid refractory, the commonest drug that patients are on in maintenance therapy. And we all know that these patients have a very low progression-free survival after Revlimid refractory. And this was a 1-to-1 randomization. Patients were allowed to have bridging therapy if they were choosing to, if they were randomized to cilta-cel, whether they get the pom-velcade-dex or darpom-dex. And after that, these patients were infused after maybe a couple of months with the CAR T cell after lymphodepletion. The whole purpose of this was to actually look at the efficacy, the safety, and also the patient-reported outcomes, which is the quality of life. So this was an interesting study because, as we know, we have rarely seen randomized trial that compare 1 versus 3 drugs. So we are talking about here a cilta-cel versus 3 or triplet therapy. So that's what is an amazing and interesting study about it.
So what did the primary endpoint, which I believe was progression-free survival, turn out to be?
Well, I mean, the interesting part of the progression-free survival here is that the patients for the cilta-cel, the median progression-free survival was not reached, but the 12 months PFS was 76%. For the cilta-cel, comparing to the standard of care, was only 49%. And that's actually amazing and impressive. You're talking about the one treatment versus triplet therapy in these patients. So it actually shows that there was a very clinical significant improvement in these patients who received cilta-cel versus the standard of care in this case.
And what about the chances that a patient is going to benefit?
The best thing here is that if you look at the results, the response rate in those patients who got the cilta-cel, you can see the response rate was about 84%, 85%, versus the standard of care was 67%. But the most impressive thing is those who got complete remission and more was about 73% versus 21%. Even those patients who got an MRD negative that was available 88% versus 32% in the standard of care. So in my opinion, that's really very impressive to have one treatment to get the patient in complete remission on MRD negativity. I think the duration of response, 12-month duration of response was also impressive. In the cilta-cel arm, 84% stayed in remission 12 months versus standard care only 63%. So that actually indicates exactly that this treatment is as effective as possible compared to the standard of care.
And what about the side effect profile?
I think that was a lot of questions and concerns, especially you're talking about moving the CAR T cell treatment from later lines to early lines. The cytokine release syndromes always have been always a concern at the beginning, but if you look at the results, although most all the grades was present in 76%, only 1% of these patients have grade 3 and 4, and all these patients CRS symptoms resolved. The median time to onset disease was 8 days versus duration was only 3 days. So we can say that the CRS was really manageable. I think the most concern side effects that everybody have is the neurotoxicity, the ICANS especially. Those patients having headache, worst scenario getting seizures or brain edema. So this was, I think, the main concern. Although there was 20% in all the grades, only 3% of these patients have grade 3 and 4. The majority of these patients' symptoms were resolved. So I think that's the only major concern that most medical oncologists will be curious about is the neurotoxicity. However, if you look at the benefit and the risk, you can see the benefits still outweigh the risk in these cases.
So we're obviously going to, at the end, kind of come back and distill what this means for your practice. But before we do so, let's talk about the other CAR T trial. Could you put this in context? Obviously, tell us about the design, but how does it differ from the CARTITUDE 4 study?
Absolutely. So we also have to know that there was also there's two CAR T cells that targets the BCMA, the CELTA cell that we talked about, and now we have the IDA cell also. Both of them were designed in the first trials after 4 lines of therapies, and it was really successful. The Karma 3 trial was different as a designation comparing to the CARTITUDE 4. These patients have a little bit one line later comparing to the CARTITUDE 4 study. They have 2 to 4 lines of therapy. These patients were daratumumab exposed and also PI and MED. The percentage of patients who were triple refractory to myeloma in these cases was about over 50% comparing to the CARTITUDE 4. So you can see that the patient characteristics was different in this case. These patients also were randomized, but randomized 2 to 1, ide-cel in 254 patients versus standard of care were more options. The patients either get darapomdix, daravelcade-dix, ixazomib rivlimid-dix, elotuzumab pomdix, and some cases carfilzomib dix. So the standard of care was like more options comparing to the CARTITUDE 4 trial. However, one of the things about this study is that this study, although it was actually aiming for the progression-free survival, or the patients who progress on the standard of care arm were allowed to cross over to the ide-cel. So that's something that we rarely see in a lot of myeloma trials. So that was really something impressive about that they allowed these patients who progress on the standard of care to receive ide-cel after progression. And that helps a lot for the patient care.
And what was the results of this study?
So the results of the study, as expected, comparing to the CARTITUDE 4, showed also that there was a benefit in terms of progression-free survival. The median PFS for the CARTITUDE for the KarMMa 3 trial was 13.8 months versus 4.4 months in the standard of care. The 18 months PFS rate was about 41% versus 19%. Now, a lot of people, unfortunately, they make a wrong comparison between KarMMa 3 and CARTITUDE 4 by saying like this is kind of like showing that the CARTITUDE 4 show better results, but you have to understand that the patient characteristics and the number of lines of therapy was different. So we can't make that comparison. It's like comparing apples versus oranges in this case.
And what was the likelihood of responding here?
The likelihood also was a little bit lower comparing to CARTITUDE 4, but however, that's expected, but still impressive. 71% of the patients in the ide-cel arm, have a response rate. Those patients who got complete remission and better was about 44% versus only 6% in the standard of care, and that really actually was impressive. The MRD negativity was observed in about 35% of the patients who got the ide-cel arm versus only 2% who got the standard of care. The median duration of response was 16 months or 17 months versus only 10 months in those patients who got the standard of care at that case. So really, actually, the results showing that CAR T-cell was better than the triplet therapy in most of the cases.
And how was it tolerated?
Most of the time, I can say that the same situations was is like the CAR-T studies. The CRS was observing 88% all grades. 4% of the patients got grade 3 or 4. The neurotoxicity was observed in 15%. Still, they have some grade 3 and 4 neurotoxicity with 3% of the patients. I think the infection rate was a major concern with the grade 3 and 4 was about 22%. But overall, again, the benefit outweighed the risk in these cases. The majority of the patients, like who have a lot of issues and death, was mainly from the disease progression in both sides.
So now let's just distill this into how you think this is going to change your practice, these two clinical trials. Are you going to start CAR T cells on everybody in second line and beyond now? How are you
Yeah,
going to
that's
think through it?
Yeah, that's a really great question, and there was a lot of controversials about this thing. And here's a few things that we have also, Dr. Ravi, that we have issues about getting slots for CAR T cell. That was one of the issues. Now, if that issue is solved, I think also we have to be thoughtful about who are the patients. So a patient who have well-known end organ damage, in the beginning of the diagnosis, and their markers are going to be elevated, I'll be really kind of like the person who say I want to push the CAR T to be given to this patient, especially the high risk myeloma patients. The patients who are having just biochemical relapse and it's barely elevated and smoldering, I'll be careful to consider CAR T for them, especially if they have a low burden disease. We have been seeing some patients who barely have minimum elevation of the kappa light chain or the M proteins, and maybe a little bit as plasma cells in the bone marrow, and we see that everybody wants to give CAR T for these patients. So I get very worried about these patients. So I'd like to make sure that, I don't want to wait for these patients to have a very bulky disease and aggressive form, but also I don't want to also, if I can control the disease with other triplet therapies or adding more or adjusting their maintenance therapy, they'll be a better option than just giving them CAR T cell because I definitely will need the CAR T when it really comes in the time. So we have to be very thoughtful. Do we move all the patients to the CAR T? I think the answer is that not all of the patients. We have to be very thoughtful for that and very selective in that term. But it's now considered as, for patients who are really, well known that they have end organ damage or have aggressive disease, that we consider CAR T as the first option in second line of therapy if we can get it.
So going forth, which line of therapy do you predict that your use of CAR T will be maximal in? Will it be second, third, fourth, or fifth line and beyond like we do today?
Yeah, so I think mostly we are doing now second line of therapy for most of the patient and third, right? It's going to be. So I think that's what the two lines of therapy that we're going to actually see the CAR T. I don't think we're going to see 5 or 6 anymore.
So you indicated that for second line, you're going to choose your patients, those who are early relapses, high risk, who are, having more than biochemical progression. So in the second line, what proportion of your patients do you think fit that set of criteria?
Yeah, that's a great question. I mean, I think I will say like at least 40% to 50% of the patients that will fit, and that is still a big number. And I will be very careful with the other 40, the other 50% of the patients, maybe monitoring them closely. But I have been seeing like, these patients, when I monitor them closely, that, they're really doing good on the standard of care treatment. They're having less side effects and they're tolerating the treatment and their myeloma is not getting out of control.
So for patients, are you going to, for the average patient, say who progresses 5+ years after a transplant, has having a biochemical progression, then going to leave it more to the third and later line of treatment?
Well, I mean, so if you can repeat the question regarding the transplant.
No, I said that for a typical patient who, for say, goes 5 years post-transplant at time of progression, has a slow biochemical progression, in that case, are you going to mainly be using it in third line?
Most likely, yeah. If I can actually try to get this, if it's a biochemical relapse, and it's not a high risk myeloma, I'll try my best to see if we can avoid, if especially if it's a low burden disease, which it looks like it is, to see if we can delay the CAR T in these patients when they really need that.
So suppose a patient is in third line, but he hasn't seen all the five drugs that we talk about as penta-exposed. Uh, for a typical patient, are you going to uh, insist that they get through their Kyprolis, get their pomalidomide if they haven't seen it in third line? Or do you think that there's an advantage in some patients to just leave that for later and just go CAR T?
Well, I mean, again, I mean, if these patients are really progressing, like, and there's like, like high risk disease, I will kind of like make sure that I can give these patients CAR T. However, if they're really slowly progressing, low burden disease, I will try other options before I consider CAR T. I will look at that. Is there any major benefit of doing CAR T in a patient have low burden disease, standard risk, they're barely having biochemical relapse? My opinion is that I'll try something else. And I've tried that before, like adding, let's say if patient was on Revlimid and adding daratumumab, and I got these patient in remission and kept them in remission for years. So I will be very, very, I'll look at the history of these patients, the history of their progression before I consider CAR T. A patient who is really aggressively progressing or his new mutations is apparent in the bone marrow biopsy, I will say that that's considered like as a red flag, and I'll consider like, why don't we move on to CAR T in this case?
So are you seeing patients come and ask you for CAR Ts even when they have other options on the table because they want to just get a treatment and potentially not have to come repeatedly to get treatments every week, every 2 weeks for extended periods of time, even if other options exist?
Absolutely. So that's really a great question. And I wish I have the best answer for that because here's the problem. CAR T is a great treatment, but you can see from the lines and you can see from the last Legend study that all patients, if not, most of the patients, will still relapse after CAR T. My biggest concern here is that if we give CAR T to a patient who didn't need it now, and then after that we really needed it in the time that we got that one option out of out of our way. That's my biggest concern. CAR T is a very effective treatment. Unfortunately, it's not curable. And I think that theory about like let the patient take CAR T and enjoy their life, that's a great theory if it was curable. But if it's not curable and you're giving the patient the CAR T that they really didn't need at that time, and let's say the patient was on this treatment, which I agree, it's annoying because patient have to come either weekly or in some cases monthly for treatment. But let's say that treatment is still working and still effective. Why switching the treatment if you really don't want to do that and wasting that CAR T at that time? You'll need the CAR T eventually. I know that, but why now? So that's my biggest uh, concern is that if we miss get that opportunity by giving these patients CAR T earlier.
So there have also been some reports of delayed neurological toxicity, secondary AML, MDS, some also secondary cancers that are perhaps due to the CAR T construct itself. Do these weigh into your decision on where to go with CAR T in what line of therapy?
Absolutely. And I think that was one of the things that we always discuss after, unfortunately, like, have we seen neurological toxicity, like delayed neurological toxicity? Yes, we did. We have unfortunate cases. So we review prior to that, like retrospectively, was our decision right when we give that patient CAR T? The answer is most of the time, all the time, was yes, because if we never give the CAR T at that time, the patient will die from myeloma. So that's a reason why we actually look at these things like the MDS and secondary cancers plus the neurological toxicity and make sure that these patients get the right option in the right time. However, again, in some cases, like high risk myeloma who have possible end organ damage, giving the CAR T in the earlier line, like second line and third line, is reasonable because we know these patients are going to need it. We will have difficulty to control the disease later on in the third and fourth line of therapy because most of the time, with now the quadruplet moving up front and most of the some centers are actually still treating patients with doublet therapy that make it very difficult to control the disease later on. So it makes a lot of sense to move the CAR T just because to give a chance for these patients to utilize it.
And what about the people who say there's no survival advantage?
It's an unfortunately tricky question here, because you can't say that word in general without any um, advantages. We have our own study we did in our health system, and we saw the benefit of BCMA targeted therapy over a year, a survival benefit for those who got BCMA treatments, whether it's belantamab, CAR T, or bispecific. So I really have to disagree about that, although there's no prospective studies right now, but we have to make sure that, that's an accurate statement. Like, there there is definitely, I think, I believe there is there will appear like a survival benefit in these patients. It's too early to talk about that right now, but I'm talking about penta-refractory myeloma patients. We saw there was an overall survival benefit. these patients didn't have a lot of chances to survive. And when we give them the BCMA directed therapy, they have survival benefit after that. So I think there's my disagreement about that. And number two, um, you have to also look at the other factor. You mentioned it's a one-time treatment. Let's say the PFS was similar between these two drugs. Would you prefer to give CAR T versus giving a patient triplet therapy? If I want to look at quality of life and I have that option, I'll give the patient CAR T over triplet therapy. It's a one-time treatment. How many times we get calls about patient wants to do procedures, go to a dentist, do a colonoscopy, or have surgery. You have to stop the drug. You have to wait. And how many times the patient got infection, you have to hold the treatment off and on. So the CAR T is a one-time treatment. You don't have to worry about all these procedures that go backward and forward. So there's two major reasons. I believe there is a survival benefit, although we don't have these mature studies right now. But I also think also there's a good quality of life that we have to look at it also as well, and make sure that we provide it for our patients.
Well, Abdullah, I can't thank you enough for taking the time to educate our audience about these new options available to our patients and how you are thinking through using these. I hope I can return to you in the future to talk to the audience about some additional burning topics in the future.
Absolutely. And I again thank you very much for hosting me.
Thank you.